Next speaker coming from India, Dr. Zubin Marolia. He is integrative medicine homeopathic physician practitioner in the city of Mumbai since 28 years. Dr. Marolia has a unique distinction of being invited to present his work since the first version of the IMM till now. He is one of the most senior integrative oncology in India, using mistletoe therapy in all ways, subcutaneous, intravenous, intratumoral. Dr. Marolia has worked at integrative medicine clinics all over the world. For example, Memorial Sloan Kettering Cancer Center, New York, Felder Clinic, Medical University of Vienna. And Dr. Marolia also believes the aim of physician not just remove disease, but to promote well-being. And the talk, it will be about the end of life care in cancer, application of intravenous mistletoe therapy, dying with dignity. Please welcome Dr. Marolia.
Thank you, Adam, for the very kind words of introduction. And dear colleagues, friends from all over India, the US, Israel, Vienna, I'd like to start by a short introduction of my mistletoe journey. My mistletoe journey started in 1991 at the Lucas Clinic, where I had attended the first conference on anthroposophy. And since then, it's been a most wonderful journey, a journey where I have seen patients, treated patients in different cancer stages, preventive, curative, palliative. And today I talk on a topic which is very, very sensitive and very, very solemn, end-of-life care, which I'm sure that most people involved in cancer treatment must have been faced with a very delicate situation of encountering a dying patient. And what do you do when you see a dying patient? And when do you withhold therapy? When do you give therapy? It becomes a very, very sensitive and a delicate decision. So I'll be sharing two cases which I have seen in this particular scenario. And 94, I worked in the Lucas Clinic, and then I'm using Helixor since the last 12 years. A warm namaste to you all. End-of-life care in cancer, application of intravenous mistletoe therapy, and dying with dignity. I think the last three words are very important in end-of-life care. What do you do when you die? So what happens to a person when he's actually dying? The first thing is that he sums up his life. Have I worked enough? Have I been loved enough? Have I cared for people enough? Have I made enough money? And have I been loved by my family? So we start, this is a very nice quote that I've always believed in. The fear of death follows from the fear of life. A man who lives fully is prepared to die at any time. End-of-life care. How do you define end-of-life care? Care given to people suffering from a terminal illness that has become advanced, progressive, incurable, is defined as end-of-life care or EOL care. It includes, as we all know, physical, emotional, social, and spiritual support for patients and their families, and encompasses palliative, supportive, and hospice care. So what are the four main pillars in end-of-life care? The first one is physical, the physical needs of the patient, ensuring that the patient and the person dying is physically comfortable. The patient is able to move, being mobile, which is so very important for the quality of life in terminally ill cancer patients. Even a few steps become very important. Mental and emotional needs, helping the individual cope with distress. Spiritual needs, assisting the patient in any spiritual or religious needs they have. Practical needs, providing help for the individual and their caregivers in testing times. So medical intervention, we know that whenever we give a medicine, whether it's to a child, to an elderly patient, to a cancer patient, what do we want when you give a medicine? Any medical intervention must operate within the confines of a reasonable possibility to cure, ameliorate the condition of the patient, improve and restore a quality of life that is satisfactory to a patient. So this becomes the most delicate decision in end-of-life care. When do you withhold therapy and when do you withdraw therapy? So if you look at a very, very short definition, withholding of therapy refers to the concept of no therapeutic escalation by DNAR. Do not attempt to resuscitate, do not escalate orders, or we have withdrawal of therapy is defined as the removal of a therapy that was started in an attempt to sustain life, has become futile, and is now just prolonging the dying process. So this is what happens to a physician when he's encountering the family, the relatives, and the dying patient. We all know that medicine as a profession is said to be a profession that taxes the brain and the heart of a physician in equal measure. EOL discussions require a gentle balance, an art of conveying medical facts very, very compassionately. And here, it's very important that the physician, when encountering the family and the dying patient, has to be very careful about conveying the facts, the tone of his voice, the words he uses, the touch that he gives the dying patient and the family. Who are the pivotal people, the main people in a dying patient scenario? I have firmly believed, and in my experience in Mumbai city, while visiting patients at home and in a big hospital, the family doctor becomes very, very important in the decision-making process, or what we call the general practitioner or the primary care physician. So you have the family physician, you have the oncologist, the relatives, the nurses, and the caregivers. So this is the slide wherein a dying patient is looking for help, support, advice, guidance, and assistance in the dying hours of his life. I'm sure every one of you, when faced with a patient who is dying, the critical decision of when to let him or her go, when you take the call so that the soul departs. The biggest crisis a patient and their family face in a serious terminal illness is when to let go. This delicate decision involves gentle firmness, the way you talk, clarity of explanation of the situation the family and the patient is facing, empathy that we are not abandoning the suffering patient, and support that we are always there. So when you see a dying patient, in my numerous years of faced with advanced cancers and terminal illnesses, I see a lot of anguish. I see a lot of personal distress that a patient faces. And while doing this presentation, I wanted to identify a new concept which I want to introduce to you all in the aspect of how do you assess the personal distress and anguish that a cancer patient or a dying patient experiences. So we have what is called a psychological pain. And sometimes we negate. Patients come and tell us they have a headache or they have a backache, and many a times we negate their pain. So is there something like psychological pain or emotional pain as defined as an unpleasant feeling or suffering of a psychological, non-physical origin? I have coined the term according to Hindu texts, ancient Indian literature and Hindu texts, as the pida, the personal distress and anguish, as the pida. So what is pain? Let's go to a classical definition of pain by the IASP, the International Association for the Study of Pain. And as we all know, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. This was a definition by IASP in 2007. It concedes that people do report pain for strictly psychological reasons. In many situations, you have to go by the patient's word, I feel pain or I don't. There's a lot of text and literature by the IASP on this concept. And they have categorically given in the conclusion that if people regard the experience as pain, and if they report it in the same ways as pain caused by tissue damage, it should be accepted as pain. And you can't describe a word of pain or distress in an end-of-life care scenario. So PIDA, as I mentioned to you, and the concept of total pain was beautifully described by Cicely Saunders, the founder of the modern hospice movement in England. And she says of total pain, impairments, disability, and handicaps, psychological distress with grief over loss and change, social disruption, and spiritual distress. Why is this happening to me? Why am I being punished? And I've always led a good life. I had shared this slide in the 2016 IMM when I spoke on cell death and apoptosis. So we know viscamalbum being used. In India, we use it, have been using it for 35 years as a subcutaneous therapy, and I have used it as an IV mistletoe therapy in the last 10 years. So IV infusions, in short, IV mistletoe infusions induce a rapid modulation of the immune system and anti-angiogenesis effects. A study assessing humoral cell responses in cancer patients' serum to mistletoe extracts administered by subcutaneous compared to IV application showed a distinctly greater stimulant effect on the immune cell populations. So what are the beneficial effects when you give IV? And we have been giving IV to cancer patients, Helixor M and A, which I'll show you in the next slide. So what do you see the beneficial effects? Reduction of psychological pain and PIDA. And here I would like to mention a very, very subtle concept of when you give a medicine to a patient. I teach at the Medical College Hospital of Homeopathic University in Mumbai, and we always look at 3 findings in a patient when you give a remedy. The first is, I ask my patient, do you feel fresh? Second, do you feel more active? And third, do you feel lighter in the body? So freshness, activity, and feeling light, these are the very subtle changes that I ask my patients when we treat patients in private practice and in the hospital. So with IV mistletoe, let's go quickly. You have reduction in the overall psychological pain and improved well-being, better vitality, and better mood. In one of the studies, and one of the patients of advanced pancreatic cancer with subacute intestinal obstruction, when IV mistletoe was given, it was helpful to lessen the agonizing abdominal pain and improve the appetite. Not only that, the patient was able to have the comfort of sipping her favorite drink, lemonade, in the last few minutes of her life. And this is a report of an advanced breast cancer patient who saw me in the city of Surat, about 4 hours from Mumbai. And she came to us with this large lesion with extensive ulceration. And she was given, as they say, 6 months to live. So as you see over here, I mentioned the dates which you can follow. Chemotherapy, 3 cycles. She was given adriamycin and doxan. She developed pancytopenia, and she was bedridden, severe difficulty in walking, low appetite, low mood, and weakness. So I visit her in her home scenario, as it is very important to see a patient at home. And here you see the prediction, 6 months to live. This is a very interesting slide wherein I am a firm believer in instilling hope till the last moments that you die. And this is a quote from a book, Mind Over Medicine, by Lisa Rankin. And it says that some data exists of a research protocol for a chemotherapy drug called EPO, which had marginally positive results. But one oncologist was demonstrating wildly successful outcomes. Why? Rumor has it that he switched around the name of the drug protocol when he discussed it with patients. Instead of injecting his patients with EPO, he injected them with hope. And this goes to show of the deep anguish and the problem the patient faced. Patient is diabetic, and she had what we call the deep psychological pain, what I call the personal distress and anguish, or the PIDA. On examination, and she says, I have lost the will to live. And then I ask my favorite question to all the patients, say, tell me your story. Tell me your healing story. And then she mentions about her son's divorce and the difficulties she faced in her life. So we start with mistletoe and homeopathy. Helixor M was given subcutaneous, and Helixor 50 milligram peritumoral. There was local dressing with an agent that we use in India in homeopathy for dressing of advanced ulcerated fungating wounds called Huang Nan. Mother tincture for local dressing, and we call in the physiotherapist for mobilizing and making the patient walk. And she had an event of her son's divorce wherein she lost confidence, she had severe back pain, had a fall, and that is when we gave her IV mistletoe, intravenous mistletoe, and we continued with homeopathy. So we gave her Helixor M, 300 milligrams diluted in normal saline, once in 2 weeks. I even give it very often. So these are the findings of restoring dignity in a patient wherein she's able to walk a few steps. I think that's important for the patient. That's end-of-life care. And this was a case that we saw at the Homeopathic Medical College Hospital with a huge fungating ulcerated wound. And she told us, I asked her, what do you want from me? And she says, I want to be with the family. When I sit in my house, I see the family members leaving. Thank you. And I want to talk with the family. I don't want to feel embarrassed with the odor of the wound. And she was given homeopathic medicine. I'd like to conclude my talk by saying by a very nice quote, if the push towards life-sustaining technology were balanced with options for comfort care in both medical school training and healthcare culture, more people would have the chance to transition to death with dignity and grace. I thank you for your patient hearing. Thank you.
Thank you, Dr. Marolia. Another brilliant presentation. Recently, we invited Dr. Marolia for a conference in our hospital in São Paulo, Brazil. Everybody loved your conference there. Thank you. Some questions to Dr. Zubin Marolia? Please, here.
With this last case, did you do the peritumoral injection for that to shrink it so she was allowed to spend time with her family?
Sorry, I didn't understand.
The peritumoral injection, did
Yes.
you do that with this last case?
Yes,
that you
yes.
showed?
No, not the last case, the previous case of breast cancer. Not the
Okay.
last case.
Not the last one.
The last case was prescribed a homeopathic remedy for the fungating odor. She had a very odd situation that when she used to sit in her house, the odor from the wound was so massive that family members would very subtly leave her. Of course, they wouldn't tell her that they're leaving, but they would sit for a moment and they would smell, the whole house would smell. So we gave her echinacea for gargling and for swallowing, and a homeopathic remedy for the odor. Because she wanted to die with dignity, she didn't want family members to leave her in her own family setting.
Okay, that's great. And on the peritumoral injection, could you explain what you do with that? Is it just one, is it?
We had given to this patient 10
Problems?
milligram at 12 o'clock, 6 o'clock, 3 and 9 o'clock. And we gave it for about 2 times, but the moment we began the IV, we stopped the peritumoral injections.
Okay.
So
thank
we
you.
began with subcutaneous and peritumoral, and then we gave subcut and IV.
Okay, perfect. Thank you.
Other question?
I guess it was a very serious lecture.
Dr. Kenny,